Welcome everyone to today's IFAM webinar series. I'm Ron Ackerman. I direct the Institute for Public Health and Medicine, and I have the distinct pleasure of introducing today's speaker. I want to remind people that when we do these webinars, if you have questions for the speaker, we will reserve time at the end for some question and answer period. Please use the Q&A function on the bottom of your Zoom menu rather than the chat function, as we will not be monitoring the chat for questions. Use the Q&A box. Dr. Jamie Druckman is the Payson S. Wild Professor of Political Science and Faculty Fellow at the Institute for Policy Research at Northwestern University. He's an expert on how people form political preferences and make economic and social decisions in various contexts. He researches the relationship between people's preferences and public policy. Dr. Druckman is a member of a 50-state COVID-19 project, which was launched in March of 2020 to identify links between social behaviors and virus transmission. We are delighted to have him with us today, and his talk is titled Racial Bias in Perceptions of Disease and Policy. Please join me in welcoming Dr. Jamie Druckman. Jamie.
Thank you very much, Ron, and thank you very much for having me, and thank you very much for everybody joining during the beginning of January, and I hope everybody had nice holidays to the extent possible. And so the talk that I'm presenting today is entitled, as Ron said, Racial Bias in Perceptions of Disease and Policy, and it's co-authored work with Sophie Trailwater and Nana Belkuso Habib, who are psychologists at the University of Virginia. And let me start by putting this in a little bit of historical context in terms of how race has been thought about historically, and particularly Africa. And so I'm going to start with two quotes from two historical books that some of you might be familiar with. They're kind of classic books. The first is from Mary Vaughan in her book, Curing the Ills, Colonial Power and African Illness, where she says, Africa, it seems, has been created as a unique space, as a repository of death, disease, and degeneration. Another quote from The Arrogance of Race by George Fredrickson, where he summarizes, in societies affirming the absolute value of individual liberty and autonomy, the only effective way to justify slavery was to exclude its victims from the community of man. And so building on those, the idea of claims about Africa as a repository of death, disease, and degeneration were often used to justify colonization of Africa by European powers. And there's a long litany of work showing that. And then here's another quote from 1864 from a member of London's Geographical and Anthropological Societies. It will be hard work and the Africans will probably become extinct. We must learn to look at the result with composure. And so indeed, the classification of people into distinct racial groups was not formalized until slavery transitioned into a transitory state, from a transitory state to a permanent and hereditary one. And these historical narratives have actually evolved into something that is quite prevalent in psychological research. And this is because it led to the evolution of the claim that Blackness was a separate and ancestral race closer to apes, and that natural selection had eventually produced the more advanced European. And so today, Black people continue to be dehumanized in subtle and not so subtle way. And so I'll just give you a few examples from more contemporary research. This is from a content analysis that was done from looking at articles from 1985 to 2008. And it looked at articles discussing racial differences where they invoked genetic basis for disease in terms of racial differences. And what you can see is, starting particularly with the start of the Human Genome Project, is that you saw a significant increase in the number of articles. These were New York Times and Associated Press articles. You saw a significant increase in the number of articles that connected racial differences to genetic differences over time. It started to decline a little bit in the late end of the first decade of the 21st century, but you can still see overall quite a large increase. Turning to psychological processes, I could show you a variety of different studies on this, but I'll just show you one and then take from results from data that I'll show you later. One common scale to look at this type of racial bias is what's called the dehumanization scale, and there are a variety of these, but one of them asks people to respond. Some people think that people can vary in how human-like they seem. According to this view, some people seem highly evolved, whereas others seem no different than lower animals. Using the sliders below, indicate how evolved you consider each of the following individuals groups to be. And then there's usually, as we did in one of the studies that I'll talk about later, you provide 10 or 15 different groups of people, and you see how people score them. And in some of the data that I show you later, we even find that people scored Europeans at 4.5, which is the highest score on the scale would be 5, would be completely evolved, and Africans at 4.37, which, while not dramatically different, is of statistical difference and is consistent with a very long line of research along these lines, and replicated probably dozens of papers that have shown similar dynamics. Another type of approach to doing this, which would be looking more at subconscious connections, since that is a self-report in some sense, is a paper where, this is just another example paper of many from which I could have chosen, a paper by Goff et al., where they subconsciously prime people with black faces, white faces, or no faces. So they did this by showing faces very quickly beyond their conscious awareness. And then they asked people in a distinct task to rate what type of animal it was that they were looking at. And what they showed is what in the right part of the panel where it says 8 images, that's the number of frames of the image that it took people to identify the animal as an ape. And what you see is that when people were initially primed with a black face, they needed much fewer frames to identify the ape than when they were primed with a white face or no face. Again, showing that there's some subconscious connection between evolution and the extent of evolution and blackness. And so what we do in our work is build on these types of phenomena and these types of dynamics. And we consider whether perceptions of disease, going back to the historic narratives that I mentioned earlier, and specifically diseases that have the potential to become pandemics, reflect this kind of deep prejudice. So the question is, are people more worried about diseases from Africa than elsewhere? And what are the consequences for policy preferences? And we'll mostly look at travel bans and abortion restrictions, which I'll explain in a little bit why abortion restrictions. And the expectation based on the historic narratives and the large body of psychological work, which I just showed you a few samplings from, is that people will become more worried about diseases originating in Africa than in other locations. And that will in turn lead them to be more likely to support a travel ban and loosen restrictions on abortions, again, for reasons I'll talk about later in terms of the specific way we describe the disease. And so for the rest of the talk, what I'm going to do is I'm going to talk about 3 experiments that we did from February to October 2019. And these were all conducted pre-COVID. So we were actually studying these possibilities on hypothetical pandemics before COVID began. Then I'll talk about a content analysis we did of media coverage of the Zika virus from 2015 and 2016 to look at if coverage differed when it talks about Africa. And then I'll talk about an experiment that we did this fall, extending our prior work to the COVID pandemic to see if these dynamics that we discover in the pre-COVID era carry over to our actual experiences in contemporary times. And then I'll conclude. And so I'll just go right into the experiment since the expectations are fairly straightforward. Oh, sorry about that. So the sample for this experiment was 803 individuals recruited from Amazon's Mechanical Turk. It was about a 59% male sample. It was an overly white sample. The average age was about 37. And the design was very straightforward. It was just a 4-condition armed experiment. We were just looking for people's reactions to a hypothetical pandemic in an African country, specifically Nigeria, an Asian country, specifically Vietnam, a European country, specifically France, or a North American country, specifically Mexico. And what we did is we offered people newspaper articles modeled on actual articles about Zika from 2015 and 16. So we took an actual New York Times articles and we just edited it appropriately to talk about one of those specific countries and also to talk about a hypothetical pandemic. And so the only thing we varied was the country impacted. Everything else in the articles that people read had identical content, holding disease symptoms, severity, and trajectory constant. And coming back to why we were looking at loosening abortion restrictions, is that we did mention that the most notable health consequence was the impact on pregnant women and their fetuses. So the idea is that fetuses could inherit these diseases. And so one of the policies that we looked at was whether that there should be a loosening of abortion restrictions given the possibilities of fetuses inheriting these diseases. And so here's an example of one of the articles from the African conditions. So you can see we call the disease Azuska, similar to Zika. Disease grew deadlier with a small mutation, study suggests. And then we talked about a study. And you can see where I circled here where the treatment came in, is that we talked about this occurring in Africa, and then we talked about specifically having a devastating effect in Nigeria. And so analogous article from another condition with the content held constant, analogous but slightly different picture because we wanted to use actual pictures, but all of the pictures had an infant and a caretaker. And this is the same article, but again, instead of mentioning Africa and Nigeria, we mentioned Europe and France. And so otherwise the content of the article was held entirely constant. So after people read one of the 4 articles to which they were assigned, we were interested in 3 particular outcomes. One was a composite of worry questions. And so these were questions like, how worried about contacting this disease would you be if someone in your community had recently traveled to the country, so Nigeria or France, for example. How worried about contacting this disease would you be if your significant other had recently traveled? And there were 6 similar items, and they were all asked on a 4-point scale, and they scaled very well together at an alpha of 0.96. So we created a single aggregate measure of how worried you were about the disease. Then we were interested in 2 policy attitudes. One was a travel ban. Given the potential transmission of the disease, do you think the US should place a travel ban on this country? And it was a simply yes or no answer. And then given the potential transmission from pregnant mother to fetus, do you think this country should loosen restrictions on abortion? And again, a straightforward yes or no answer. So here are the results. Let me talk through how to read these results. So the results show each of the key outcome variables, and each bar is from one of the countries of interest. So for example, if you look all the way on the left side of the scale, and the y-axis is the score, and I rescaled all of these on a 0 to 1 scale. And so they were a regular scale across the dependent variables. And so the first 4 bars show the outcomes on worry, and the first bar shows how worried people were in the Nigeria condition. And what you see is that the score, average score in that condition was 0.54 when we rescaled it from a 0 to 1 scale, which was significantly higher than the scores in all the other conditions, which are the 3 subsequent bars, respectively France, Mexico, and Vietnam. And so when we move to the second set of bars, which is the question about travel ban, what we see is 34% of the people in the Nigeria condition endorsed having a travel ban on Nigeria, while 20% endorsed that in France and Mexico, which is significantly less, and 28% for the Vietnam condition, which is marginally significantly less than the Nigeria condition. And then when we move to the last set of conditions, we see 70% endorsed loosening abortion restrictions in Nigeria versus 58 and 57% in France and Mexico, and 67%, which is the one result which was not statistically distinct for Vietnam. But overall, we see fairly good, consistent support that Nigeria led to significantly greater worry, travel ban support, and loosening abortion restrictions support relative to all other countries except Vietnam. The 0.28 was marginal, but we could say on the 2 policies if we want to be very strict. And those results are robust if we implement multiple correction comparisons. We then looked for mediation to see if the worry mediated the opinions about the travel ban. And so what we did is we simply wanted to know if the exposure to the Nigeria condition increased worry, which in turn shaped policy opinions. And so we just simply used a straightforward mediation software, the process software, for those of you familiar with that. And what we found is fairly strong evidence that the mediation did not include 0 for either the travel ban or the loosening abortion restrictions. Or put another way, what the results showed was that an African versus European, Asian, or North American disease led participants to worry about the disease more, and that worry in turn increased support for loosening abortion restrictions and a travel ban. So those are the results from our initial experiment. We moved into a second experiment where the idea was to replicate the design fairly in the same way, but we did 2 things that were different. One was that we used a different sample pool. For here, we used an in-person subject poll from the University of Virginia. It's because we wanted to see if it mattered in the mode of exposure and with a different group. So these were students. And we also included individual difference measures related to race and racism. So for example, we asked people the dehumanization scale that I showed you earlier, where people were asked to indicate the extent to which different groups, including blacks or whites, were fully evolved. Here we did it on a 0 to 100 slider. And so let me just move into the results because it's the same design. And so what we see here are the results for worry. And here we find that, again, Nigeria led to significantly greater worry, marginally significant compared to France, statistically significantly more worry compared to Mexico and Vietnam. Interestingly here, we did not see main effects on the travel ban or loosening of abortion restrictions. So that's why you don't see all those bars in this graph, because you would show pretty constant effects across those conditions. So this contradicted the results from the other experiment. However, when we go to look at the mediation results, what we find is when we look at the travel ban, we do find fairly clear evidence that the increased worry did in turn lead to increased support for a travel ban. So we see some indirect effects of the country in terms of the African Nigeria country increasing worry, which then in turn increased the support for a travel ban. So there's no main effects, but again, those worries were related to greater support. And so there was an indirect effect. We don't find that for loosening abortion restrictions. So we don't find any effect in this experiment for loosening abortion restrictions. And we speculated, again, this is speculation, that may be due to the sample being a younger, more liberal, and more female sample with less malleable attitudes when it comes to abortion specifically. So with those results in hand, we wanted to do this one more time in a third experiment. I'm sorry. Before I skip to the third experiment, I should mention that we also looked at the moderation effects of dehumanization. So if you recall, we also in this experiment measured the dehumanization measure, as I mentioned, and here we do find results of moderation as we would expect. So specifically, higher scores on dehumanization predicted stronger support for a travel ban, but only in the Nigeria condition. That is, people who had more dehumanization of black individuals were more likely to support the travel ban in the Nigeria conditions. And so that's consistent with the racist narratives that motivated these studies in the first place. So again, with those results in hand, we move to one final experiment, pre-COVID experiment. And here we wanted to look at to see if the results, we wanted to really isolate to make sure that these results were being driven by racial differences, and they weren't being driven by perceptions perhaps of the country's ability to contain a pandemic. So for example, one critique of the last two experiments could be that it isn't the racial differences, but it's that people had differential perceptions of these countries in terms of their health and healthcare infrastructure, population density, travel, mitigation, and so on and so forth. So what we wanted to do is we wanted to control for factors known to promote the spread of disease to pandemics. So here the sample was a mechanical church sample, a fairly large mechanical church sample, and the design was largely the same, although we used different countries in this case. So we replaced the countries, and this time we used Germany, Ghana, Brazil, and China for the countries from those continents. So the other big change in this experiment is to make sure we controlled for those disease-related spread variables. We also asked a set of questions, and these are just 3 examples of 9 questions that we asked. Overall, how densely populated is this country? How good do you think the country's healthcare infrastructure is? How economically developed the country is, and so on and so forth. So we wanted to make sure when we control for those perceptions to see if the African country, in this case, the Ghana treatment, had the effects that we had seen in experiment 1 very clearly and somewhat in experiment 2. And so here are the results. You should be familiar with these types of graphs by now. So these are the results for worry in the travel ban. And what we see in the first bar is Ghana. And we see when it comes to worry, we see that there was significantly greater worry in the Ghana condition relative to all the other 3 countries, Germany, Brazil, and China. And when it comes to the travel ban, we also see significantly greater support for the travel ban when it comes to Ghana versus Germany, Brazil, and China across the board. But again, as in experiment 2, we did not see a significant main effect on loosening of abortion restrictions. So it seems like that policy, we found some evidence for that in experiment 1, not in experiment 2. And again, we didn't find it in experiment 3 either. So when we turn to looking at mediation and the spread variables, we found here, unlike experiment 2, we found evidence for mediation for both the travel ban and, in this case, loosening abortion restrictions. So specifically, an African disease led participants to worry about the disease more, which then mediated an increase in support for loosening abortion restrictions and a travel ban. And then importantly, again, the point of this experiment was to make sure these results hold when we control for perceptions of different infrastructural aspects of the country. And we find that the results hold for when we do control for those variables that I mentioned before. And in fact, interestingly, when we put in those controls for the variables, we find a marginally significant main effect on condition for loosening abortion laws in Ghana versus the other countries. So we start to see when we put in those controls actually a main effect on abortion restrictions. And so what we did then is we took all 3 sets of experiments, and in fact we had started a small replication of the third experiment, but that was cut short by logistical issues. But we included the data here, and we wanted to do a meta-analysis. That is an analysis where we aggregated the results from all of these experiments, the 3 experiments I've shown you, in the partial data collection that we began but had to cut short. And we wanted to put those together in an aggregation and look at each of the 3 outcome variables to see what we found. And so I won't talk you through the columns, or I'm sorry, the rows are just the results from each experiment that you've largely seen already. But the bottom results in a square is what do you get when you aggregate the results across the experiments in the meta-analytic technique. And what we see for worry, which is not surprising given that we had seen consistent results across the experiments, is that we find a very significant effect that in the African conditions in those experiments, we see significantly greater worry when we aggregate the experiments. When we turn to the travel ban and we aggregate across the 3 experiments, or the 4 experiments, what you see again, not surprisingly, given the results were consistent with the exception of experiment 2, we see strong, significant support for African condition leading to more support for a travel ban. And then finally, when we aggregate them for loosening abortion restrictions, even though we had gotten inconsistent results across the experiment, when we aggregate them with a meta-analytic technique, we find significant results for the support for loosening abortion restrictions when it comes from the African condition. So when we look at these meta-analytic results across the experiments, in some, people are more worried about diseases originating in Africa, and those worries shape policy support, in this case, support for a travel ban and support for loosening restrictions on abortion. So the next study we turned to, before I turned to some COVID-19 considerations, was an archival study. And specifically, we were interested in, do the racist narratives that we found to be at work in these experiments appear in other manifestations, in particular the media? And so what we did is that we examined language around the Zika virus pandemic in 2015 and 2016. So just a little bit of a very brief primer on the Zika. The Zika virus was first identified in Uganda in 1947. The first large outbreak was reported in Micronesia in 2007. And of course, in 2015 and 2016, many of you might remember there was an outbreak in Brazil, which spread to other South and North American countries. But very importantly, in 2015 and 2016, it never reached the African continent. So any reference to the African continent in coverage would have been to the early origin in 1947 in Uganda. That would have been the reason for talking about Africa. And so what we did is we searched 9 major newspapers, including the Wall Street Journal, the New York Times, the Washington Post, the Chicago Tribune, and a set of 5 other major newspapers with Los Angeles Times, with major readership and geographic spread. And what we did is we identified all articles that mentioned Zika from 2015 and 2016. So this was just below 1,500 articles. We then identified the articles that mentioned Africa or an African country in the article. So 19% of the articles, of those nearly 1,500 articles, mentioned Africa. And then we also counted how many times it mentioned Africa in those articles that mentioned Africa. And then we used software to analyze the content of those articles. And specifically, we use the software to look for 3 different types of content. One is the emotional tone, particularly looking for negative emotional tone. 2 is death-related words, and 3 is risk-related words. Then we also looked for the use of personal pronouns. And the motivation for us doing that is that we thought that there would be use of fewer pronouns when Africa was mentioned in the article would be consistent with a dehumanization narrative, insofar as you wouldn't want to humanize by using personal pronouns. And so what we found, this is a messy table, so I'll talk you through it. Is what we did is we basically just regressed each of those outcomes in terms of the content on whether the article mentioned Africa or not, or the sum of the number of times it mentioned Africa, controlling for word count and outlet and other aspects of the coverage. And so the first columns, not sure if you can see my pointer or not, but the first column where it says tone is basically a negative tone, and what it shows is that those articles that mentioned Africa were significantly more likely to have a negative tone. And if we use instead as an independent variable the number of times it mentioned Africa, we see very strong results of a relationship with a negative tone. In terms of death-related words, we see very strong relationships when Africa was mentioned, or the number of times Africa was mentioned, a very strong increase in the number of death-related words. We do not see any relationship with risk-related words, which was counter to what we expected. We do see a significant significant decrease in the number of personal pronouns when Africa was mentioned, or the number of times Africa was mentioned. So in some newspaper articles that mentioned Africa in their Zika coverage, more negative in tone, use more death-related words, and fewer personal pronouns, but they did not use more risk-related words. And so that kind of covers the archival study, again, consistent with the 3 experiments, insofar as we're seeing that this racist narrative of disease is carrying over not only in people's reactions to pandemics, but also in terms of media coverage of pandemics. And so we had completed these studies, as I mentioned, prior to the beginning of COVID, but of course this raised all kinds of questions about do the dynamics that we're seeing, do those carry over in perceptions of COVID? So we then conducted a study this past October to look to see if these results and these dynamics apply to COVID-19. And so we did. In October of 2020, we recruited a nationally representative sample of people in the US. So here we use a vendor that conducted, it's a non-probability, but quota-based sampling. So it's a little bit more of a diverse and representative sample than our prior experiments on Mechanical Turk. And we recruited 1,200 people. And the design of this experiment was a little bit different than the prior 3. We randomly assigned participants to one of 4 conditions about a hypothetical, what we said was a hypothetical, well, we didn't say a hypothetical, but a democratic country in Europe or Africa. We didn't name the specific country. And the 4 conditions varied 2 things. It varied whether we talked about a European or an African country in Europe or Africa. And then it also varied the COVID rate in that country. So we talked about a low COVID rate, which at the time we said was 5% positivity test or death rates of 65 per 100,000, or a high COVID rate, which would be 15% positivity or 170 deaths and 170 deaths per 100,000. So the COVID rates that we used were baselines at the time. So in the low condition, that was basically what was going on in the US at the time of our study. And the high totals were basically the high totals that we were finding in the high cases in the US. So that was specifically from New York, at kind of the highest cases in New York. We also gave respondents a host of information about the country's infrastructure, poverty rate, education level, and demographics, and urban population, gender, and so on and so forth. So again, people were reading kind of hypothetical descriptions of what was going on with COVID in a specific European or African country, where they were given information about the infrastructure of that country, told it was a European or African country, and giving COVID rates in that country as either being low or either being high. I should note as an aside, and using Africa as an interesting case, because as some of you might know, Africa, in terms of as a continent, has done remarkably well relative to the other continents in COVID. So these are just graphs of the number of cases by continent. And you can see at the bottom there, Africa has done exceptionally well in controlling the number of cases. And one might ask why, and these are some of the reasons that we found that people are putting forth why Africa has done so well. Is that across the continent, they had quick action. There was general public support for COVID action. It's a relatively young population in a favorable climate, and there's generally good community health systems on the ground, are some of the explanations put forth. This is an aside simply to show that it's an interesting study insofar as Africa actually has been doing much better than Europe, which is our comparison case in terms of controlling COVID outbreaks. And so the outcomes that we looked at in terms of people kind of read this description of, think about a hypothetical African or European country, here is some information about the country, here are the COVID rates in the country. And then we asked people a similar worry composite from the other experiments. We asked them a travel ban question, that is, should there be a travel ban on this country for people coming to the United States? And then we asked them a travel restriction question, that is, in terms of should there be a full ban or should there be restrictions in terms of the number of weeks of quarantine, or should there be free travel back and forth? We then asked spread-related variables similar to what we did in the third experiment that I talked about previously, and then we asked a bunch of racial attitude scales. And so here are the results. And let me talk through how to read these results, because obviously given the design of the experiment, it's a bit different than what you saw earlier. The first set of bars, the first 4 bars, are on the worry composite as earlier. And the first bar is from the European, and again, these are all rescaled on a 0 to 1 scale. And the first bar is the European case with low number of COVID. And so what you see here is a score of 0.57 on the worry scale. And the second bar then is the African comparable low COVID case. And what you see here is in the low COVID case, but in Africa, you see an increase, a statistically significant increase to 0.61. So you see changing from Europe to Africa, significantly increase the amount of worry, holding the number of COVID cases constant. And then you see in the next 2 bars, these were the high COVID cases. You see a jump from 0.61 in the high European case to the high COVID case, Africa case. So again, you see holding COVID cases constant, this time at a high level. You see a significant increase when we talk about an African versus European country. When we move to the travel ban, we see similar results. On the low COVID case situation, we see a jump from 0.53 in Europe to 0.58 in Africa, and a 0.60 in the high COVID case in Europe to 0.70 in the high COVID case in Africa. And in terms of travel restrictions, we see a significant jump from 0.48 to 0.53 from Europe to Africa, and 0.54 to 0.61 from Europe to Africa in the high COVID situation. So in every case, Africa has a higher score than a comparable COVID-19 case in Europe. So interestingly, if you hadn't already noticed, what we're seeing is virtually identical results between low Europe COVID-19 cases with high Africa COVID-19 cases. So here you see what I circled here with the high African case and the low European case. And in virtually all 3 variables, there's statistically identical, and in some cases, substantively identical scores. So having a low European COVID-19 case, people are perceiving that as the same as a high African country COVID-19 case. And then I should say that this holds when we control for any of the spread-related variables that I had mentioned before. We also looked at mediation, which similar to the process that I did in experiments 1 to 3. And we again find fairly significant results that basically what was happening was that people increased their worry about COVID, and that led to their opinions about the travel ban and travel restrictions. The moderator results are a little bit more complicated. They weren't quite as straightforward as we found in the one experiment that I discussed before on dehumanization, but they were consistent with those results. I'm not going to go into those results because they don't provide a clear picture, but they were in the direction of what we would have expected. And so to summarize the findings from these sets of studies, what we found is kind of across 3 experiments, 3 pre-COVID and 1 during COVID, is that people report greater worry for the pandemic originating in Africa versus elsewhere, and in turn they report greater support for restrictive policies. We also found in an archival study of the 2015 and 2016 Zika pandemic that newspaper articles were more negative, including more death-related words using more negative tone and fewer personal pronouns when they mention Africa or an African country. And so these findings are consistent with narratives about Africa, the narratives that I began the talk with, of Africa being a dark and diseased continent, racist narratives to use to justify the initial colonization of African people and the African land. And so concluding, and then I'll talk a little bit about some future directions, geography and racist narratives about geography seem to shape the public's response to disease, even when people have relatively large amounts of information about the disease. As we tried to add, especially in the 3rd experiment, in the pre-COVID experiment, but obviously during COVID, people had high amounts of information. We gave them high amounts of information about the hypothetical countries, and yet the geography and the racist narratives, seemingly the racist narratives about those geographies were shaping people's opinions. So worries about pandemics are obviously legitimate, and pandemics, as we are experiencing, are devastating, but policy should not be guided by racist narratives. And so we think one of the implications here is confronting the historic legacy and how it continues to shape not only in the minds, but also in the policies is necessary and urgent as we confront the continuing nature of COVID and any future pandemics. In terms of future works, as I mentioned at the end of the COVID results, we have found fairly mixed results on moderators in terms of these dehumanization type measures. And that raises the question of to what extent do the racist narratives and their impact are confined amongst a subset of the population who seem to have dehumanization perspectives, either consciously or subconsciously, or are they so ingrained in the culture that they carry across people? That is, are there individual differences, or are these pretty constant and homogeneous across people? We do not find consistent evidence on that. Also, we focused on an international context, and I didn't describe another experiment that we did, a separate experiment similar to the COVID-19 experiment, but there, instead of looking at Africa, we talked about different states, and specifically we looked at to see if people would support travel restrictions from states with particularly high Black populations, and we did not find any results on that. We varied the size of the Black population in a fairly subtle way, just talking about the percentage of Black residents, so we don't know if that was due to our subtle manipulation, or it might be that this is really an international dynamic. So that's another thing that we think is important for future work, to look at domestic implications of these racist narratives. And then, of course, there's the larger question of what are the origins of the racist narratives and what role do the media play? Do they play a role in shaping people's application of these racist narratives, or are they echoing cultural norms that are ingrained in the population? And so that's the set of studies that we had forward, and I look forward to any questions that anybody might have. Thank you for your attention on a fairly lengthy presentation.
Wonderful. Thank you so much, Jamie. That was an excellent presentation. We do have a few questions that came in through the Q&A, and I would remind people, if you have questions at this time, since we have a little bit of time to discuss them, please enter them into the Q&A section at the bottom of the Zoom panel. The first question is, is there a name for the first experiment that you showed, or any of the experiments? Are they published, and where can those publications be found if people want to read them?
Sure, yeah, the paper is not yet published. It is a working paper at the Institute for Policy Research. So feel free to shoot me an email, or you can look at the Institute for Policy Research paper series, and all of the results that I described today are in that working paper. But thanks for your interest.
Great. The second question relates to that the findings that you showed in the experiments, indicating a racial bias, are consistent likely with lived experience of many individuals that experience racism. Do you think the findings provide insights between the relationship of Black Americans or Black people living anywhere and their trust for medication or vaccine or the health system in general? Can it, is it a potential undercurrent that explains the less trust potentially in the advice of a white doctor, recommending what they should have done for a pandemic like COVID?
Yeah, that's a terrific question. And in some sense, we're connecting to a literature that has looked at healthcare across race and racial bias in healthcare, typically unconscious bias in healthcare, in which a lot of you might be familiar with that. There's fairly large literature showing extensive bias and different types of training programs that people have tried to implement to eliminate that types of bias in terms of care for Black patients by white doctors. And so, so I do think that these results carry over insofar as some of the same dynamics that we're demonstrating might be the same types of dynamics that you might see on a more micro level in terms of interactions between healthcare providers and non-healthcare providers. Some of our own prior work that I've done with these co-authors was looking particularly at pain perceptions. So outside of a pandemic area, but looking at pain perceptions and whether people have perceptions that Blacks have higher pain thresholds, which would then lead providers to provide less care because they perceive them to have higher pain thresholds. And that's a consistent finding that we found, that there's a perception that Black individuals have higher pain thresholds, which leads to less care. And so that's one example of the type of racist carryovers that you could see in particular healthcare. So I do, coming back to the larger question that I think is being gotten at, leading to trust in medicine by African Americans, that I do imagine that, we've heard lots of people talking about African American hesitancy to the vaccine, which the early surveys before the vaccine was let out was quite concerning. And I think the data so far is that there's been much higher uptake in the vaccine across races than anybody anticipated. But I do think that those numbers, those initial numbers, reflected obviously what everybody talked about in the history of kind of the horrific trials, of course, the Tuskegee trial, the most notable, but I also reflect lived experience that minorities have had with the medical system. So there's a very long-winded answer that I do think that this is kind of all consistent with that work.
Next question. Do you think that the racist narratives that you uncovered in your studies may have shifted more towards Asia, or with respect to the emergence of COVID-19 in China?
Yeah, that is such a great question. We actually really struggled in the design of the COVID experiment of trying to think about including Asia condition. Because so I don't have a direct answer to that question. I think it's an excellent question. We ended up not including an Asia condition, obviously opting instead to kind of look at the four conditions that I showed you, and then the analogous experiment looking at states instead of countries. But it would have been quite interesting to look at an Asian. It obviously would have been different dynamics in terms of the dehumanization. There's interesting work on dehumanization in Asia. The larger concern that I've seen in terms of Asian and dehumanization is that people often have stereotypes of Asians as kind of almost of machine-like rather than ape-like. So how that would have carried over to prejudice in terms of a pandemic would have been an interesting thing to study. So I agree. I think that there probably would have been some interesting dynamics. And in retrospect, that may have been more interesting to do than the state level study that we did. But yeah, unfortunately, we didn't collect data on an Asian continent in that study.
Another question is whether you or your team have plans to examine this relationship more in the U.S. context through additional experiments, possibly with more intense or direct manipulation.
Yes, yeah, we actually do, and so that's an excellent question. So there are two things I think that could have been going on in the manipulation and what we were looking at. One was the manipulation we used basically talked about another state, and it said that it gave population figures from the other state, and in the low race condition, we said that there were 12% African Americans, where in the high state condition, we said there were 28% African Americans. So that may have not just been a large enough, people in manipulation checks certainly observed those differences, but that just might not have been enough to trigger any types of conscious or subconscious racist attitudes that might be underlying this. But another possibility is that these just are not applying in the same way in terms of travel bans and travel restrictions. And maybe that's just too severe of a policy in the United States to be looking at. So I think a more interesting thing that we've talked about is, instead of looking at travel bans and travel restrictions, is looking at the allocation of resources and kind of allocation of the vaccine we could be looking at, or we could look at of economic aid going forward, even in the post-pandemic era, and kind of seeing if allocation and how much you would allocate resources depend on the makeup of that community and the composition of that community, and whether the extent to which it contains minorities of African Americans, but also Asian Americans would be quite interesting to look at too. So the answer is, I think, perhaps more interesting than trying a different manipulation would be looking at outcome variables rather than travel restrictions, but to be the allocation of resources, of finite resources that we have. So that is something that we've talked about of doing.
Another question we have really relates to the what next, and the question about knowing this information and putting this together with maybe other research and what we know about structural and systemic racism that's prevalent throughout our society. What's the potential? What sort of actions can we be taking, do you think? This maybe extends beyond your work, but just to mitigate against our biases so that we can begin to address social determinants of health and the things that sort of are in our environment and in the structure of our society that sort of create race differences in health and inequities in health.
Yeah, I mean, I'm not an expert in kind of the policies that have been putting forth and the types of training programs that have been put forth in that way. So I think kind of two answers to that. One is kind of just being more conscious of these discussions. So, for example, at least for me personally, had I not been doing this work, I don't know if I would have been aware of the rates in Africa right now and how well Africa has done as a continent. So I think kind of, highlighting things like that and having more explicit discussions in policy discourse would be helpful to acknowledge, and in particular in the case of COVID, to kind of put more attention on some of the countries that have done so well and why they've done so well in Africa. And so that's one thing to be doing. On a more micro level, I know there's kind of, as I mentioned, there's a lot of programs in place in medical schools to try to get at implicit bias. And I know there's a lot of debate about the impact of racial training programs more generally. I've done a little bit of work myself in a different domain, looking at the impact of debiasing programs on perceptions of people with disabilities, varying the type of disability and race. And there we did find fairly strong effects of debias people who have participated in implicit bias training. So I think the impact of those programs are debated, but I think they're worth continuing to pursue and discuss. And then also really trying to isolate what is the underlying mechanism of the bias. So for example, coming back to the work that I just mentioned, what we had found in this work again, I'm kind of talking about different work here, so I'm getting off on a bit on a tangent, but in the case of people with disabilities, we had found that some of the racial bias that we found with people with disabilities was coming from, and it was exacerbating perceptions that these people were not hard workers, particularly when they were African Americans with disabilities. And so kind of isolating the mechanisms that led to the type of bias then can help create programs and discussions to try to mitigate those biases.
Jamie, another question we have is whether you think that racial biases differ with age, and whether, as if you compared younger white U.S. individuals or citizens to older, would evidence of evolutionary stereotypes be different, do you believe?
Yeah, that's a great question from Joe. I don't know the data on that, but I will my co-author Sophie probably would know, and I will contact you, Joe, and let you know if I get any information about that. That's a really good question. But I'm unaware. I mean, we could even look in my own data, but I hadn't looked at our own data by age. So that's a great question. One interesting thing though in our data is that you do find, even amongst Black individuals, you do find some of racial biases, which is surprising to me, but it does seem to be so culturally inbred that it's a great question if the nature of the culture has changed amongst young people, that's altered at all. But yeah, I don't know directly, but I will try to find out.
Jamie, I have one last question, and it's whether you've used this work with even federal or state policy audiences, I think highlighting and making them aware as they sort of think of enacting things like travel bans or other restrictive policies that relate immediately to COVID or future pandemics. If you think that there's any action how can these results sort of shine light in the eyes of policymakers who are making these decisions, so that even if it's implicit, that they're aware that there are these biases and they're perhaps more thoughtful about how they make decisions and how quickly.
Yeah, we have tried to highlight these results. So it's actually been a really wonderful experience for myself. As you mentioned in the introduction, I'm a member of this large consortium team that's what's called the COVID States Project. And actually this particular project is not part of that consortium, but it's related. And what that consortium is doing is that we've been collecting a large amount of data. We've done now 14 surveys beginning last March, where we have about 25,000 respondents to survey, because we're trying to get large enough samples by each state and DC in the country. And we've been tracking all kinds of things related to COVID, including, if not especially, racial disparities. And we've looked to distribute that information quite widely to in the media and with policymakers, thanks to the support largely of the Institute for Policy Research. And we have tried to put a large emphasis in many of our reports. We've written 30 reports now on this project. If you're interested, the website is just covidstates.org. And we have tried to accentuate racial differences in many of the reports to make people conscious of the different experiences. And we have tried to communicate. In fact, we were lucky to connect somewhat with the Biden transition team to talk about the importance of kind of messaging about the vaccine and taking account of different considerations that different minority groups might have in that messaging. And so we have had conversations about that, trying to think through the implications of that and kind of the types of messaging that might be most effective in that sense. And so, and I mentioned this has been a very interesting experience for me, because prior to this project, I had kind of not actively been involved in a lot of this type of advocacy or work with media and policymakers. And so it's been an interesting experience to kind of be part of this large project, trying to look at things in real time. Obviously, in the project I presented today, it was as we discussed before, earlier on, Ron, before we started, it was a bit of an unfortunate irony that we were studying this prior to COVID started, and then COVID started. It's not something we ever had imagined when we began this project in particular.
Well, Jimmy, I want to thank you on behalf of the IPM membership and the remainder of our audience today. This is a wonderful talk, and we thank you for sharing your findings with us. As we conclude, we're a bit early. I don't know if you have any sort of parting comments you want to leave us with before we say goodbye to the webinar today.
So yeah, I just want to thank everybody again. I hope the project was informative to some of you, and as we go forward, I think racial considerations, not only as we move through the vaccination phase, but I think one thing to really keep in mind is what's going to happen post-pandemic, insofar as once the country hopefully will reach a point of vaccination and herd immunity from the vaccination. The implications, one of the things that we're really trying to look at in the COVID States project are the long-term implications, and the fact that different groups have experienced the pandemic in very different ways, and both along socioeconomic lines. We have one group of people with high socioeconomic status that have kind of created a microcosm world of being shielded from most of the most dire consequences, and another group of people who have kind of lived these most dire consequences due to population density and less access to healthcare. And we have seen in that project, this is carried over to physical health and mental health. The mental health data in particular are really quite shocking. We're finding people with what would be clinically depressive symptoms on the order of 35 to 40% of the population, whereas during pre-COVID times, it was more like 3 to 5% of the population, I believe. And that's also disproportionately amongst young people, in fact. And kind of the post-pandemic impact amongst different groups, including racial minorities and young people, is I think something that we have to keep a very sharp eye on, because we can't just forget there were disproportionality in the impact of COVID, but that disproportionality can have very long downstream consequences for years to come. So I just would encourage people to kind of keep those considerations in mind well after COVID is over, and kind of the rebuilding after COVID and thinking about those types of considerations. So I guess that's a parting thought that I would like to mention.
Wonderful. Thank you so much today again, Jamie, and thank you everybody for joining us. I assume if we have anybody in the audience has further questions, they can either send them to the IFAM email or can email Jamie directly on his university email, and I'm sure he's happy to answer. So thank you so much again, Jamie, and everyone have a wonderful day.
Yeah, thank you so much.
Bye-bye.